Hola.
Hello. I forgot you were talking to me. I thought you were talking to the audience. I was like,
We're going Spanish today, Chris.
Yes, hola. Necesito practicar mi español con mucho personas. We're gonna scratch that. But I need to practice.
That was good. Hey, we do need to practice our Spanish. So
I know.
like
you know what? I was gonna say. When I was working around a lot of people that spoke Spanish, and I was living at home where my dad speaks Spanish, and my younger sisters and stuff, it was like, I'm so good. And then you get out of that situation, you're just not as fluent. So.
Lose it all. Yeah, it's sad, right? But it's there are some amazing Spanish speaking clinicians. Chris and I are not one, but they do exist, and we would like to work on that. So maybe that could be one of our goals in the future.
This would be a great lead-in. I know that they're having the the Spanish-speaking conference this year, and I think I believe so, that they're still having the what do you call it? They're still having submissions open until the end of this month. Yes. So if you are watching this, proposals. Thank you. If you're watching this and you're either a clinician that specifically works with the Latinx population and speak Spanish, or if you're an individual with OCD who wants to share their story with lived experience, definitely head over to iocdf.org, I believe, /conferences, and definitely submit a proposal. So that was the whole reason that we spoke a little Spanish
today. Look at that. See, there's always purpose behind our randomness. And you can also go to iocdf.org /ES, where you can visit IOCDF in Spanish, which is amazing. So many great resources. And again, this is just one of the many things that IOCDF does that sometimes we don't even know about. And then we start talking, and we're like, oh, wait, there's resources that already exist. This is so cool. So welcome, everybody. Thank you all for joining. Please say hi. Let us know where you're joining from. And please make sure you put any questions that you have in the right-hand pane that you see over in the comment section so that Chris and I can get to them. Welcome to our live stream titled Ask the Expert. So this is a stream that Chris and I do twice a month, and we really like to do this stream to focus on just answering questions. These should be more clinically focused questions. We have some pre-submitted that we will certainly get to today, and I already see at least one or two submitted that we will definitely answer live as well. We always do our best to get to your questions. If we don't, we will make sure we write them down and address them during our next live stream. For more information on live streams, updates, what we're doing, go to iocdf.org /peace of mind. This is our landing page where you will find out about every live stream that we're doing, but it's also where you can submit questions, comments, content that you want us to cover. And we absolutely take all of that into consideration. And Chris and I are constantly reading it. And Chris is emailing throughout the night talking about, did you get this? Did we not? And so it's always on our mind and agenda. We take it really seriously, and we hope that you will actively participate so we can better serve you, because that's the goal. So Chris, how are you? Welcome. Excited to share the stage with you today as always.
Yes, I'm so happy to see you. So I just saw Phil. So first of all, hi to everybody that said hi so far. And Phil was saying there's a big storm coming in the UK. And for me, where I live, we had hail last night, and that's like unheard of in Southern California. So I was running a support group, and all of a sudden it sounded like somebody was like throwing glass at my office windows, and I go outside and it's just hail. So we never have hail. So that was like crazy. So welcome, Phil. I am so glad you're joining us before your big storm. Hi, Betsy. Hi, Zach, who's in Washington State. Dave said hi to us. I don't know how you feel, Liz, but it's always good to see our community come out and support this stream. And we're just so eager to give back to y'all, but we're so happy that you guys come out and support us. So thank you, everyone, for coming out.
Totally. We love having you guys here. And really, we love being able to cover things that are important to us, but more importantly, important to you. And that we hope that our education will be useful in some way. So next week, I wanted to give a little plug. Chris and I are going to be joined by Dr. John Grayson, where we are going to be talking about the misconceptions of ERP, the way ERP is done wrong, but also how we do ERP correctly and what allows individuals with OCD to get the most benefit from this treatment we are also often talking about. So it'll be an amazing live stream. Please make sure you join. And if you have any questions around ERP, or you're like, ERP doesn't work for me, or it hasn't, submit that to that iocdf.org /peace of mind page so that we can make sure we address it in our live stream next week. That one is a lunch and learn focused on ERP. So let's hop in. Chris, where do you want to start? You want to start with questions submitted, or question pre-submitted, or live submitted today?
Let's start with live, but I want to start with the first question because I literally got it when I was promoting this morning, and I think you'd be good to answer this. a lot of times I'm going to paraphrase the question because it was pretty long, but a lot of times we hear people that say, look, ERP doesn't work for me. And that was the question I got. They said that they feel like ERP doesn't work for them. And I didn't get a chance to respond. And I pointed them here. I was like, and some, hopefully they're watching, but what would you say to somebody that maybe comes to you or comes to the office or your own experience that says, hey, like ERP hasn't worked? What are some of the things that you would respond maybe with somebody who asked that question?
Yeah, the first thing I want to talk a little bit about is what was the experience like for you and what didn't work. I will have some patients come to me who say, actually one of my patients right now who said, ERP didn't work for me and I don't know that it'll work. And so I said, tell me more about that. And as we talked, what actually happened is while the provider was qualified in ERP, they jumped straight in and didn't spend as much time in psychoeducation, and they were unwilling to answer any questions because they didn't want it to be reassurance. But the patient ended up just super confused because they were like, I need to understand what I'm supposed to be doing and why. And I understand later on why you might not answer reassurance or questions, but early on, like, I truly don't know this versus that and what I'm supposed to be doing versus that. And so I think we're going to talk a lot more about this next week, but to me, it's really about what did ERP look like for you? Did there need to be more time spent in readiness? Were you ready for ERP and bought into it? Because if you're not bought into the treatment before we started, it may not work. The second is, are you really understanding and starting to learn, right? And allow yourself to engage in true learning that will allow you to be able to accept the concepts as ERP as a lifestyle or the concept of that versus ERP for every specific symptom. And we're going to get so far into this next week, which I'm really excited about. But I think there's a lot of ways ERP can be augmented and should be to work best for you, right? If Chris, you and I would have gone to the same provider and they just wanted to do a standard ERP approach, we wouldn't have had the same benefits. Treatment for OCD should be individualized. Should be specialized for your symptoms and what you're dealing with. And so what I would say is, like, tell me more about it to try to make sure that we can kind of deconstruct the problems that may have happened and also specialize it to work for you. The second piece is, Jeff Szymanski and I talk a lot about this, is that rapport and a relationship is more important in a therapeutic alliance than ERP. If sometimes ERP doesn't work because you and the clinician just may not have meshed and it may not have been the right fit. And maybe like their strategies or the way they explained it didn't work for you. And the reality is that when we're doing ERP, we have to have a good rapport with you. We have to trust each other. We have to have this working relationship. And so I think there's a lot that goes into it. The second piece I will say, and Chris, you and I talk about this a lot because Chris will often refer to our clinic, which does more intensive residential support, and I often refer to Chris for outpatient and intensive outpatient, is, are patients ready? And sometimes what we find is that while ERP is the treatment they might need for OCD, they actually might need something else first, right? So if someone's really struggling with emotion regulation and self-harming, for example, ERP is not where we're going to start because it's going to dysregulate you more and it isn't going to work. You're going to get more stuck in the process versus being able to get benefit from it. And so DBT is the treatment that we would really recommend first. So I would also want to know that is maybe ERP didn't work because of the way it was being utilized, right? The implementation of it that can be addressed, or was it that there might be other things that need to be integrated first? What are your thoughts on it?
Yeah, I'm glad you're saying all that because a lot of times I know people come into treatment and it's hard because you and I have both a personal connection with the treatment because we've gone through it and we've dedicated our lives to it. So when people tell me that, I don't want to immediately just say, you know what, it doesn't work for you. Like, go to harsher, like more extreme measures. Let's look at, TMS or that's not harsh, but you know what I'm saying? Like,
Yeah.
Magnetic,
PBS or
any of that kind of
things,
stuff. Yeah. A lot of the things you already covered it. Maybe one other thing I'd add is sometimes you might need to work in conjunction with a psychiatrist to start with medication. Maybe the anxiety is just so intense for ERP. And then one thing that, the way that my therapist framed ERP to me, which is sort of what I hear in ACT, is it felt less of me like doing treatment. And it was more so identifying these obstacles that were in the way for me getting my life back. So then when I was in treatment, it was always like, what are some of the things you miss? And I'm like, oh, I super miss going to a restaurant. All right, let's do ERP around that. So I never felt like I was doing treatment. Somebody during our live stream 2 or 3 weeks ago one of our guests said, ERP shouldn't be fear factor. And I never felt that way for my treatment. I really felt like, hey, these are the exposures you have to do to get your life back. And so for me, I saw value in it. And I didn't look at the treatment as this like horrible thing that's making me suffer. Instead, I looked at it as something that opened up opportunities. So everything that Liz said is so important. And I guess lastly, I'd just say, don't give up on it yet. Really find somebody that specializes in it. They eat, sleep, and drink this treatment, and make sure that all those other factors are in place. You're addressing comorbidities. Maybe you're dealing with an eating disorder, or you're dealing with depression, and that's getting in the way before you completely abandon the treatment and assume that you're somebody that can't get help, because that's when sadness, loss of hope kicks in, like the person that asked this question, and then they just are sort of giving in.
And I will also say, I think sometimes we get nervous to talk to our providers about how we're really feeling. Talk to us about it. Like, that's like literally what the therapeutic relationship and environment is for. Like, I want you, if you're my patient, I'd want you to say to me, Liz, like, I just want to be candid that like, I feel like this isn't working. And I feel like I'm struggling to get ERP to click for me. And like, I'm not understood, because I need to know that. It's going to be much more detrimental if you are like, let me just keep giving her a chance, even though I don't think this is going to work. And then I keep doing what I think might be useful, when really I need to be pivoting, or I need to be thinking about something else. And so have that conversation, right? Talk to your provider about that, because I think that's really important for you to be able to be open and vulnerable, and for them to have that conversation. If they're not willing to, that's concerning too, right? We should all be saying, oh my gosh, okay, like, thank you for bringing this to my attention. Let's talk about what's going on. And let's talk about ways we can address it. So I had a question that was submitted as well this morning that I wanted to talk about for a second. And the question was, what do you do if a loved one really needs treatment, but they don't think they do, and they don't feel like they need it, but everyone else can see that it would be important for them?
I do a lot of work with Barbara Vanapin out here in the West Coast. She's on the board of OCD SoCal. And the more that I've done work with her, and she's done so much, she coined the term family accommodation since the early 80s. Before you and I were even born. And so I just know she knows that stuff. And so the more and more I work with her, she's at USC and she talks, and it's like, this really is a family disorder. This is really something that impacts the family. And so what I always ask families, if they come to me, the first thing I'll say is, let's have an honest conversation about reassurance, enabling, and accommodation. What are the things that you do on a daily basis to further empower and give the OCD an audience? And a lot of times they'll give me this like 2 to 3 page list, and I'll say, what's happening here is your loved one is able to sort of continue to live life as is, and they don't feel the strain of the disorder because there's so many other people with their hands in the pot helping to lift the OCD up. And so they're able to get through it, and they aren't realizing how big of a problem it is because they're still able to get their needs met. No, I don't believe in just like cutting everything in one day, kicking them out, being harsh. You don't need to take that to the extreme. But if the person's at least willing to come to a therapy session, or even if they're not, you come to an OCD specialist, and then you can approach your loved one with resources, information. I always give them links to us advocates, true, success stories. If still after that they're not interested, then what you can do is start as a family member, give them a heads up in a calm moment, but start to let them know that you're going to be pulling back the accommodation. And as you slowly pull it back, remember, you're not going to pull the rug out from under them. What starts to happen for most individuals is the OCD's true kind of heaviness and weight comes out, and they start to recognize like, oh, wow, now that my family's not doing all these things, there's not enough hours in the day and I'm really struggling. And so then they can sometimes come to you and say, you know what, you're right, I do need to get some help. And so I would say for me, and I'd love to hear what you have to say, Liz, but for me, that's kind of like the first go-to spot. And the last point that I'll give is, a lot of times pick the kind of media that person likes. Do they go to YouTube all the time? Do they listen to podcasts? Do they love to read articles? And send them in that fashion some of the success stories that you can find on the IOCDF's YouTube channel or the IOCDF's web page. And they may, while they're starting to have to pick up their own compulsions because you're backing off, sometimes hearing those stories of hope can be a good adjunct and people can feel motivated.
Absolutely. And the other plug I'll give is to consider programs like the SPACE program that Ellie Leibowitz has developed. And it's really, this is a program that's specific for family members of loved ones struggling when we find that the loved one may not either be making a lot of progress, or the family members are like, I know I need to be integral in this process. There's a lot of options, and a lot of providers, like a lot of clinics, like ours included, have family therapists where the family can go to the therapist even if the individual isn't willing, so that they can help support you with that individual's specific kind of struggles about what to do and what might make sense. Because again, this should also be individualized, right? Chris and I can't just say reduce accommodations and you go home and reduce accommodations. Like, that's not what we mean. We mean like do it with a team, do it with support of a therapist, and do it individualized for yourself and your loved one.
Absolutely.
All right. So, Will, I will answer your question quickly because the answer is I don't know, but I think I know where to send you. So the question was, how are studies on vaccines? Do they make OCD worse, like Yale studies? And is anyone concerned? So I would actually encourage you to, this was just happened last week, so it won't happen again until another month, but I would encourage you to go to our live stream. That's our research live stream. So this is, what is it, Chris? The second?
It's every second Wednesday at 9 a.m. my time, Pacific Standard
noon
Time.
Eastern.
Yeah.
So yeah, second Wednesday, noon Eastern, Dr. John Abramowitz and Kyle King do a research symposium where hopefully they can answer this question more effectively than Chris or I probably can. I'm sure there are studies, but I don't personally know of any specific studies right now on vaccines and OCD and the way it impacts them, but they may know more than we do. All right, 11:01 a.m. from Kaja. Chris, I will throw this to you. How to overcome sexual intrusive thoughts?
Yeah, so I can definitely relate from a personal experience. I had sexual intrusive thoughts for sure about family members, about strangers. The way that I like to think about it, the word overcome, I like to instead think of changing my relationship with. And what I mean by that, Kaja, is that when I first was dealing with these thoughts without treatment, my relationship was to freak out, to try to thought stop, distract, convince myself, a lot of mental compulsions, a lot of fighting in my head. There was some like avoidances definitely, but I'd say the majority of the things was trying to convince myself to never do that. Or if I was in the store and behind someone where the thoughts came up, I'd act like I had to go grab something else and go to a different line. What I learned in treatment is that I can change my relationship with these thoughts. These thoughts are not things that I have to stop what I'm doing and constantly listen to and prove wrong, etc. And so what I always tell people is I took a more, and what I tell my clients is I started to take a more passive approach. And what I mean by that is before my treatment, I was taking an active approach. Every thought I got, I had to analyze, I had to figure out, I had to reassure all of that excess energy, which then just made the OCD even more powerful, the more energy I put in. So during treatment, when I took a passive approach and lived in uncertainty and basically said, okay, I'm having these thoughts. They could be 100% OCD thoughts. They could be 100% my thoughts. They could just be thoughts. I don't know, but I'm no longer going to spend time trying to figure it out. I'm going to let those thoughts sit there, kind of hang out, do what they're going to do. But I can make the choice because I have freedom of choice and engage in other things and simply just acknowledge and sort of tolerate the thoughts and accept their existence. And when I didn't put energy into it, what I started to notice is sure, the thoughts would pop up, but there wasn't this like 4 or 5 hour response that I'd provide it. Now I get it. I mean, when you have those horrific thoughts, you almost feel guilty by not doing something about them. But I learned that just because I don't engage with them and try to push them away doesn't mean that I'm accepting them or liking them. It just simply means I'm no longer going to spend energy on it. So what I would encourage for you, Kaja, is to start to ask yourself, like, what are you doing in response to these thoughts? All of those compulsions are actually what's feeding this and making it come back stronger and more powerful each time. And in response prevention, as you pull back and stop engaging with those thoughts, you'll start to notice that they become less loud and less frequent.
That's right. And what's really important to remember is that sexual intrusive thoughts, contamination, harm, OCD, we treat it all the same, right? And to remember what Chris is saying that's critical is that the more we actually respond because we're afraid of them and want to get rid of them, the bigger we make them and the more powerful they become. And so it feels super counterintuitive, right? To say like, okay, well, if these thoughts bother me, I'm just going to let them be there, right? Like then they're going to bother me more, but that's actually the opposite. The more we don't respond to them and we don't show that we're afraid of them and that we have fear there, the less the fear can grow and the less the concern can continue to be there. So Phil, I will answer your question quickly because I think we just answered it. So your question is—
Yeah, I just saw his question. I was like, hey, we just answered that.
Yeah. Do you think the cause, like tell us a little bit about alternatives? So I do want to say I 100% think alternatives are important and critical. Like for some people, standard ERP doesn't work. We need to adjunct with medication, we need to think about utilizing other interventions maybe first or in conjunction with ERP. And for some people, they do need to think about more intense options like DBS, like utilizing or thinking about maybe TMS or ketamine if they're dealing with depression. But again, you want to really be with an OCD specialist, number one, and work together with them to think about approaches that would be best for you. But I definitely do think relationship with the therapist, timing, where we're at, motivation, like Chris talked about. If we're not motivated to do treatment, even if ERP might work for us, if we're not willing to engage in it, it's not going to work for us.
And I wanted to plug to Phil real quick. Phil, if you go on the IOCDF's YouTube page and you watch last week's research roundtable, what they did is they talked about, the old school way of talking about ERP is we used a lot about habituation, but John Abramowitz has talked a lot about like inhibitory learning and ACT, and these aren't necessarily different approaches to ERP. These are just ways to kind of frame it. And so sometimes framing it in a different way makes ERP make a little bit more sense. So for instance, like to me, thinking about my treatment is kind of getting things back in my life versus like, okay, we got to do the treatments, you got to get better. That kind of helped motivate me. So I would definitely look at that last week's roundtable. They're not alternatives per se, but it's a different way to approach ERP. And you could see if any of those really clicked with you and talk to your therapist and say, hey, this is how it was addressed in this roundtable. And I really like the way that they're talking about ERP.
100%. Next question is from Zachary at 1107. Can OCD come from trauma? So this is a really interesting question, and we actually are doing an upcoming webinar that you can find out more about on OCD and trauma. But what we know is that sometimes PTSD symptoms can look like OCD, checking behaviors, different reassurance, avoidance, you name it. And we also know that individuals who are diagnosed with PTSD have much higher prevalence rates of OCD than the general population. So the general population tends to have a prevalence rate of OCD of about 3%, where when trauma is included, it could be like 5 to 12% or more. And so this really, it's a good question because we don't necessarily know if trauma can cause OCD symptoms, but we do know that there's a strong correlation between trauma and OCD. However, what I want to point out is that it's really important you're working with a provider who has both OCD background and trauma background, because we need to tease apart what is trauma versus what is OCD. The reason why is that we wouldn't want to treat trauma or PTSD with uncertainty OCD type of treatment. That will make the trauma worse, can be more triggering, and can re-traumatize, and it would not be useful. And same with, we wouldn't want to treat OCD with trauma responses, right? Or not trauma responses, but trauma treatment. We want to treat it with OCD treatment. And so it's really important that you either have a team where you're working with a trauma and an OCD specialist, or somebody who understands both. But it's a great question. And I think we probably don't totally know the answer, but we do know that prevalence rates increase for OCD for individuals who also live with trauma than individuals who do not.
Yeah. And I would like to always kind of say that the way that we know it doesn't necessarily like cause is because there's plenty of people with OCD who don't have gone through trauma. But what I've heard from a lot of my clients is that they maybe had OCD symptoms that they almost never noticed until obviously like later on in life, but they were so small. And then a trauma happened and it was like opened up the floodgates. So I had a close friend that got in a really, really bad car accident. And he had talked to me about very minor OCD when he was a kid. He had little things with particularness, but it never impacted him. But after this car accident, it was to a point where he was just constantly doing compulsions. And to him, it was like opening the floodgates. So that's one of the correlations that I see sometimes. Totally.
Felice Becker at 1110. What are your thoughts on RODBT versus DBT? It's a good question. And, I will be honest, I am not super trained on RO versus DBT, and my DBT skills in and of themselves, I would encourage somebody to work with a DBT specialist if they're needing DBT stuff, because my skills are very limited. I know there is some more emerging research on RODBT and a lot to come, but I don't know that we have a lot as far as outcomes of RODBT versus DBT when we're talking about folks with OCD. So I would definitely look at the conference that's coming up in both July, the in-person in Denver, and the conference that will be online in October, and see and attend any talks on DBT and OCD, because that will be the place to get more answers. And then hopefully, Chris, this is a topic we should talk about. So we can try to make sure we jot down the importance of having a specialized talk on DBT and OCD.
Agreed. Yeah. And you've talked great about how, even when we did the OCD SoCal conference and I talked about just the anger and stuff I had as a child, I think DBT would have been great to help me with management. We had a therapist at my treatment center that came from DBT. She worked at the DBT center out here in Orange County. And the things that I remember hearing her say about RODBT is that it's kind of like more like emerging, it's more later, kind of cutting edge, and that it's a little bit more useful for disorders outside of borderline personality disorder. So you wouldn't use it necessarily to treat OCD, but especially if there's like, issues around relationships and stuff, it can be something that's better kind of utilized for other disorders outside of DBT. But just like Liz said, I don't specialize in it, and there's probably going to be plenty of talks about this at the conference because there usually is some.
Yes, so definitely attend those. Michelle Williams at 1114, I'm sorry, Michael Williams. I've just started ERP, but I've only had a couple. So my therapist and I think it might be a good idea to do some intense ERP or something else to understand OCD for many years so I can understand it better. I've had many medication, which wasn't good for me, but I'm hoping there's something new available that I can try. I've also got older and it seems to have gotten worse. My life is very different now that I'm older. So I think this is a great question, Michael. And what I will say is, first and foremost, it makes sense that if you've had untreated OCD, it's gotten worse, right? So we know that without proper treatment, without appropriate interventions, the illness will get worse and it will impact our life in greater ways than if we're seeking treatment or able to seek treatment early on. The second question around ERP intensive versus not, I think that's really up to you and your provider. And so what I always recommend is if you get started on an outpatient basis, give it a shot, right? So don't expect that you're going to see a difference in 1 or 2 sessions, right? A traditional outpatient length of stay is about 12 to 16 weeks or 12 to 16 sessions. And at that point, you should really see the impact, understand how it's going to help. And it should be either making a difference where you can think about terminating, or you're like, oh yeah, like this is working for me, even if I still have work to do. That doesn't mean you have to wait 12 to 16 weeks to make this decision. If your therapist a couple weeks in, or even session 1 and is saying like, I think you need more, I think you need a higher level of care, listen to them. That's literally what our job is, right? So my job as somebody who runs an intensive program is to be assessing if somebody needs this higher level of care and to constantly be assessing when are our patients ready to step down. Chris's job might be the opposite in the sense when we're talking about this type of work of like, do they need to step up and when so? And it is our job ethically to be communicating that with you and to be sharing that with you, because if we think you need more than what we can offer, we should be talking to you about that pretty early on. So I think work together with your provider. And what I will say is if there's an opportunity to do intensive ERP, I get the question a lot, Chris, I'm sure you do, of like, when is it the right time to seek treatment? When is it the right time to do more? And what I always tell people is I've never had someone say, I wish I didn't do as much early on, but I always hear people saying, I wish I did more. And so, if you do something that's intensive and maybe you're like, I don't know if I need this, it's not going to do anything except help, right? And it's going to just make your outcomes be faster. And so I certainly am a big believer that there can always be a benefit in it, but also know that if you're at a good intensive place who really is ethical and doing OCD work, they should also be saying, you don't need this level of care or you're ready to step down. And we actually do that in the assessment process. There's times where someone's in the assessment phase with us to enter our program and we're saying like, we actually think you should get started with an outpatient provider because you may not need this level of care.
Yeah, honestly, everything you said, I agree with. And that's part of the assessment process, Michael. And, just making sure. And if your clinician is saying, hey, you need a higher level of care, what I like about working, we do intensives out at my treatment center. And what I love about it is it gives me time to like really sit with the client one-on-one. We're going over the education, we're doing exposures together all day, like things like that. The other thing that I like is, let's say somebody has also had OCD for like 10, 20 years and isn't working and isn't volunteering and not doing much. Like that's a part of the treatment program as well. It's like getting you back on your feet. What are some of the passions you have? What are some of the things that you want to do? I always think about my own care. We didn't have an intensive outpatient program that could take me when I was, in treatment. I was severe and needed one, but every single one had like a 6 to 8 to 1 year, waiting list, and I needed to get in. So I had to do it outpatient. So when I found out what an IOP was, I was like, oh my God, I wish I would have had that. My treatment wouldn't have been like 14 months. I probably would have gotten treatment much sooner. So if you're somebody who's like moderate and severe severe and extreme. And then, like Liz was saying, you may need something even more intensive than that. And that's usually when I refer someone to Liz, is when it's somebody that they are struggling to do their daily activities of living. It's hard for them to shower. It's hard for them to eat. They're compulsing all the time. They go to an intensive program, but just go back home and then do more compulsions. And so they need that care throughout the day. So definitely, it sounds like your provider thinks you need something a little bit more intensive, I'd definitely listen to them.
100%. Okay, so Bodhan at 11:20 a.m. I have confusions if there's God or not, having anxiety surrounding the questions. If there is God, would he punish me as I'm skeptical about him? Now, how do I deal with these worries? So, Chris, will you talk a little bit about scrupulosity treatment and what it looks like if, in fact, we are talking about scrupulosity and OCD fears?
Yeah. So with scrupulosity, what I hear from a lot of the clients who have scrupulosity is the most difficult thing is that they're, me as a clinician, they know that I'm not going to have the answers. And so that's what's hard, is there's so much uncertainty around this subtype. And the problem is, let's say somebody has a health OCD, like at the end of the day, you could probably find a doctor that could give you a pretty straight answer and give you reassurance. Obviously, we don't suggest that, but it's really difficult. And even my clients that will go to their pastor or their priest will come to me and say, yeah, but he still doesn't know. And so the difficulty also is OCD asks for perfectionism in thought. So in your case, OCD wants you to never question God, 100% be certain. But that's why it's called faith. I mean, everybody who's part of the church, my dad's extremely active in the Catholic Church, and I grew up in the Greek Orthodox Church. We all go there with faith without 100% proof. And so there's going to be times that we question things, or we might not agree 100%. And somebody without OCD is okay with that. They recognize that they're on a faith journey. But somebody who has OCD, it's more of a tit for tat. I have to 100% know there's God. I have to never question it. And if I question it, he's going to be angry and I'm going to be punished for all time. And it puts you in a very difficult conundrum. And that's what OCD wants, because now you could spend all day and all night freaking out over any potential thought that you have that doesn't align with what OCD thinks you should be thinking about in regards to religion. And then you go into the compulsions like praying and confessing and self-hate as a punishment. So what we're asking people to do in all subtypes is to take a step back and really say, what is the OCD asking to do? And the OCD is asking you to 100% know that God exists and to have proof. And that's just not something any of us as people can do. And that's why it's called faith. So what we really need to do here for you is to take a step back and say, look, like, I am a person of faith, and these are the things that I want to do about it. And I'm going to have questions and doubts. I'm not going to jump on every single one and punish myself, and always go back to embracing uncertainty.
That's right. And the last thing I'll say about scrupulosity is that oftentimes when people think about ERP, they think, oh, well, scrupulosity, are you going to make me less faithful? Are you going to want me to do things that would take me away from my faith? And the answer is absolutely not. Just like with any type of OCD, when we're doing exposures, it should be exposures that are value-based and that you would do if you didn't have OCD. We should not be encouraging people to do things they wouldn't do without OCD. And so the reality is that our goal with scrupulosity is that we actually allow you to have a healthier, working, functioning faith relationship, but one that's not controlled by OCD's rules and rigidity. And what we find is that most people with scrupulosity actually start avoiding their faith and avoiding the things that they really love or used to do in the ways they used to engage with their faith, because OCD has robbed the freedom in that and the enjoyment in that. And so we want to help get you back to your faith and the things you love. And as Chris said, faith is actually the perfect example of OCD treatment, in the sense that the entire premise of faith is believing in something that isn't 100% known, right? You are accepting the unknown. You are having peace in that, and you can feel confident in it, but there's still inherent uncertainty in faith. And there's inherent uncertainty in everything in life. And that's actually the treatment of OCD across the board.
And I just want to really bank on something that you said, and I hope everybody who's new to ERP hears this. The treatment is not trying to take you out of your value system, and we're not putting you in a position across any subtype that's putting you in harm and danger, and it's not something Liz or myself would do. So if you're ever are working with someone and it feels very unsafe, or they're asking you to do something against your value system, like definitely like Liz was saying earlier, open up first and talk to your provider about your discomfort. And then at the end of the day, if they don't respect those boundaries, it might be to see somebody else. But I always explain to people, especially with scrupulosity, my goal is not to take you away from your religion. In fact, if you do the treatment, you're most likely going to be more connected with your faith.
100%. So hopefully that answered some of the questions. Will, I don't have all the answers on vaccines and OCD, so I don't want to get into that. What I will say is we certainly have seen OCD get tied into vaccines, as it has gotten tied into health OCD, COVID in general, and other things. So OCD can definitely get attached to vaccines around fears and uncertainty and whatnot. As far as any evidence of vaccines actually making OCD worse, I haven't personally heard of that. Not to say that doesn't exist, I'm not sure. So Mary, we were talking earlier, sorry, we use acronyms, and I appreciate when people put like, hello, what are you saying? Because, we need to explain it. So DBT is dialectical behavioral therapy. It is a intervention that's often used for like emotion regulation. It's used for personality disorders. It might be used for people who engage in self-harm, and it is a specific behavioral intervention to help address those various symptoms. Deep brain stimulation is DBS, and DBS, which is deep brain stimulation, is a more advanced treatment option, like later on. It's not a first-line treatment option, but it's after ERP and medication hasn't been successful, that where there's 2 electrodes that are implanted, and then a pacemaker is used to stimulate to help do hopefully OCD treatment and help individuals with OCD get some relief. DBS is a neurosurgery, is neurosurgery, so it's a little bit different, certainly much different than ERP. Why is pure OCD so difficult to treat, and what is it? Chris, love this question because it's important for us to talk about it.
Yeah, so when we hear the term pure O, what people usually mean by that is that if you were to follow them around all day, you would most likely not see any outward compulsions. You might see some avoidance, but the majority of things that people are dealing with are internal. It's very cerebral. Now, the reason I always want to give people caution is I know when I was in treatment and I first heard this term, I felt very depressed because I had sexual intrusive thoughts and I had harm thoughts. And so when I heard that, there was no compulsions that I was doing, I had learned that obviously dropping compulsions is how you get better. I felt very frustrated. But what I learned about this term and why some, clinicians don't use it is they're not saying that you don't have compulsions. Those compulsions just happen to be mental. So maybe they're mental counting, thought stopping, compulsive rumination. It can be pushing a thought away. It can be checking mentally. And so that's really what is going on there, is that the compulsions are mental. Now, why is it difficult to treat? So somebody that had a lot of outward stuff with checking, with magical thinking, with contamination, and then a lot of internal stuff with harm and sexual intrusive thoughts, I would say what makes it difficult, I wouldn't say it's more difficult, but each kind of subtype has its own unique challenges. What's difficult with this one is that if I had to go and scrub and wash things, but I was out in public, I couldn't do that. There's a level of embarrassment. Maybe I wasn't at home. But when you have mostly mental compulsions, you can sit there and compulse at the gym. You can do it at the movies. You can do it at work. And so it's so much easier to compulse. And often people don't recognize they're compulsive. They just think it's an obsession that they're stewing on. But what really helped me with this is, I recognize that what I was really doing when I was mentally compulsing is I was trying to get answers and I was trying to figure things out. And so what I learned, just like I learned with more physical subtypes of compulsions, is that my job was to no longer answer these questions. In fact, I'm going to look at the possibility that the worst case scenario may happen. And either myself at that time would be able to step up and handle it. Maybe I wouldn't be able to, but because it hasn't happened yet, that's something for my future self to deal with. But current Chris isn't dealing with that situation at this time. And I may or may not handle it well. It may or may not turn out well. That's something that I can deal with in the future. But right now, I have to just step into that uncertainty and recognize that it's not going to be solved in 5-6 hours in my head. So once I stop trying to figure things out or contemplate things and letting it go, that's when, yes, the obsession would happen, but the compulsion wasn't. It started to fade out.
100%. Okay, sorry, there's so many questions and we still have so many other ones to get through. So Chris, we're gonna have to rapid fire.
Okay, we'll start rapid fire.
How do you feel about the lack of knowledge of OCD in licensed psychologists? They seem to think it's only hand washing and wanting things organized, which is concerning due to lack of education maybe. So I'll take this one, and then it infuriates us, but this is why we do this work. There has been such an increase in education and knowledge. And I always want to say that we have seen so much progress, so much improvement, but it's hard. It is hard what infuriates me the most is when providers are treating people they shouldn't be treating. So when they say they treat 100 things, or they'll take people on just because they want to take on patients, when really it's not what their specialty and expertise is. And this is where I always push us that even though it may not be fair, it is critical that you are your own advocate. So you need to be asking the right questions. You need to educate yourself on treatment. And if what you're getting doesn't seem like it's what you need, advocate or think about switching to someone else.
Yeah, you said everything great. And I hopefully Fran can put it up. There's a really good article on the IOCDF, and it has the questions you should ask a therapist when looking for an ERP specialist. And it gives you literally a list of questions and what the answer should be. And so I always tell people, please, 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 when you call or email a center, ask those questions and you'll get a better answer.
Absolutely. So Felice, you asked about a higher level of care. So there's lots of different options, and you can look into iocdf.org actually has a link that's specific for more intensive programs. So you can see which ones might fit, which ones might take or accept insurance, or different financial means that may be preventative, or that may, figuring out which ones meet your needs appropriately, and start there. And you start by just calling, and literally you call and start engaging in the process, which can include phone assessments and whatnot, that you will start the process towards a higher level of care. Chris, Raven, thank you, Raven, for asking this question at 11:29. I'm so new to this. What is ERP?
Yeah, so like you were saying with the acronyms, we sometimes just forget, that a lot of people, and we love this. I mean, what I love about this, Liz, is that means somebody new has found the IOCF, has found our community. So we love that. So ERP is the gold standard of treatment. And I really like that there's been tons of meta-analysis of different studies that have shown that if you are in a good treatment center and you are getting ERP, like Liz said earlier, 12 to 16 sessions, you will see a reduction in symptoms on the Y-box. And the Y-box being the Yale-Brown Obsessive Compulsive Scale that it's a measuring tool to measure the severity of OCD. So ERP, the E stands for exposure and the RP stands for response prevention. So how I like to break it down to people that are first entering is E is basically putting yourself in a situation that makes the OCD uncomfortable. So let's say you haven't gone to the movies because you're afraid of sitting in seats because they're sticky, or let's say you haven't been driving because you're afraid of hitting somebody with your car. Systematically and in a hierarchical manner, you would start to face those fears. So using ERP example might be sitting in your car in the driveway if you haven't even touched your car in the last 3 years because of fear of hitting somebody with your car. Now, RP stands for response prevention. The OCD is going to be so adamant that you do a compulsion to alleviate the anxiety. So if you're sitting in the car, it might be you have OCD telling you to visualize happy thoughts. Or if you're sitting at the movie theaters, the second you leave, you have to race home and take a shower. So we're asking you to prevent yourself from doing that compulsive behavior in response. And what we do over time with that is we teach ourselves that we can deal with stress tolerance, but even better, that we learn that these things aren't dangerous. And we kind of put, like Alec Pollard says, the things that OCD says is dangerous, we start putting it into the safe category. And pretty soon you can go to the movies without even struggling. So it teaches you to not fear that same stimuli anymore.
We have so many questions. I'm trying to figure out how to get to all of them. So I'm going to skip over some, and I'm sorry if I'm skipping over your questions. It's because I feel like we've answered it. There were quite a few on Scripulosity. I believe we've done a live stream on Scripulosity, so definitely check out IOCDF's YouTube to learn more about Scripulosity, to learn more about some of the basics of ERP that we've covered, and then also to learn about some of the other topics. One question was therapy or ERP. I'm doing both, or therapy over ERP. It should be the same. ERP is therapy. We should be doing it in conjunction. One individual at 11:30 did ask, and don't worry about putting all these questions up because I'm going to answer some quickly, about real event and false memory OCD that turned into a spike of potential sexual trauma that turned into POCD, sexual orientation OCD, and relationship OCD. Would you recommend treating it with trauma? If there's trauma there, we want to treat the trauma as trauma. If it's OCD, we want to treat it as OCD, not as trauma. So that's kind of my best answer in a nutshell. But we will be having both a live stream and a town hall on real event and false memory OCD coming up in the near future. So again, check out iocdf.org/peace of mind. So many of you are sharing your stories and details. So thank y'all for sharing. Remember, accepting uncertainty is a process. A lot of folks are saying, how do you accept uncertainty? What does that look like? It doesn't happen overnight. We don't expect that you can do it on your own. You do this together with a provider, but that's what the entire ERP process is about. Good news, if you come back next week at noon Eastern time, that is exactly what we're going to be talking about, is ERP and uncertainty. So for those of you who are saying, what's ERP? Does ERP work for my type of OCD? How do you use ERP for pure OCD? We're going to address all of that next week as we really get into the nitty gritty of ERP, what it is, and a big focus will be on uncertainty.
Can I add one thing, half a second? What I would always remind people is when we ask how to accept or cope with uncertainty, the good news is you actually deal with that all the time. Eating at a restaurant, you're hoping that they're cooking the food properly and it's not expired, but it may be. Driving on the freeway, you're accepting that you may potentially get in a car accident, but you drive anyway. Same with going on a plane and things like that. So we deal with uncertainty all the time. OCD just puts a spotlight on the things that we don't want to accept and tells you you have to 100% figure it out. Whereas in real life, outside of OCD, we're able to handle uncertainty. So the good news is you're already doing it in other areas. So it's not a new concept you have to learn.
100%, right? It sounds so scary and terrifying, but it's actually what you already do every day and what your loved ones already do every day. And so it's not as hard as it seems. But when we talk about it, totally get where you're like, and here's what I'll say. Dr. Bjornson, who was my first clinician, always said, like, you should be skeptical of treatment. You should be skeptical of what we're asking you to do. That's okay. That's healthy, right? That's how you learn and explore, but give it a shot and let's see how it works out. I love having new people on here. I see so many new ones. So Tracy, visit iocdf.org and there's amazing listing there of support groups. There's the Health Unlocked platform and lots of different ways that you or family members can find support for individuals with OCD. Chris, I know we're getting a lot of great questions, which I love, but I want to make sure we get to some of the important ones that were pre-submitted. So the first one I'm going to answer quickly is, how do I find OCD resources in Spanish? My mom has OCD and it's been hard for her to engage in therapy because we need a Spanish speaking clinician. I would highly recommend you go to those two resources we gave earlier. There's an upcoming Spanish conference for OCD, and then you can also go to iocdf.org/ES to get OCD resources in Spanish. The second is there's actually amazing and a lot of Spanish-speaking clinicians. I know we have two here right now and one that's coming on as a postdoc. And so the resources exist, but you may need to go to IOCDF. I'm not sure, Chris, do you know, or Fran, I don't know if you know, if you're searching for help in the IOCDF page, can you click Spanish? Can you click language?
I believe when you're doing the find help feature, there is a button for that because there's an advanced search.
Fran says yes. Fran says yes. So yes, so you can do that as well.
Yeah.
So that'll help you just to know in your area who are the Spanish speaking providers, but they do exist, which is awesome. Okay, so in addition to OCD, some of my other diagnoses are BDD and an eating disorder. I have many obsessive thoughts and compulsive behaviors from my BDD and eating disorder, along with non-body image. Can ERP help all of these?
Yeah, so that's a pretty complex question. So ERP, when it comes to body dysmorphic disorder, ERP is part of the treatment. So an example for that is somebody may consistently check in the mirror, and their exposure is to reduce that mirror checking. And their response prevention, obviously, is to not then turn to photos or turn to videos or something to alleviate the distress of a reduction in mirror checking. However, I will say the difference when I treat BDD, because I work with a lot of clients with BDD. When I treat BDD, there's a lot of other things that we're working on that are outside the scope of OCD. So one of the biggest things is a lot of people come to me and their thoughts are very egocentric. And what that means is they really believe that there's something wrong with their appearance, specifically a few body parts, whereas somebody with OCD often comes in, especially if they're not extreme, and they'll say, look, I know that this is silly, or I know this isn't as bad, but I feel compelled to do it. So a lot of times I will have to use some more traditional cognitive behavioral therapy methods for them to really start to challenge some of their body image based belief systems. There's also sometimes we have to address like childhood bullying, or sometimes people had parents that said harsh things about their appearance. There's also a lot of things that I do around culture, because there's some people that come from a different country where one beauty standard was there. They come to America and it's a different beauty standard, and they're really feeling ugly compared to the individuals around them. I do a lot of psychoeducation on how the beauty industry and society uses filters and different things to really make people feel inadequate. So I would say that treatment for BDD has a lot of extra components that you wouldn't necessarily see in OCD. Now, when it comes to eating disorders treatment, that treatment isn't going to be an exposure response prevention in the same way. You will challenge some of your eating beliefs, but one of the biggest differences that I do when a client has comorbid eating disorders is I definitely make sure that they're getting a medical checkup. What is their weight right now? Are they at a point where they should even be doing ERP? because they might then compensate by food reduction. Also making sure that they're working with a registered dietitian to ensure that they're getting the nutrients that they need. So there's a lot of other components with the BDD and the eating disorder that wouldn't be addressed if somebody only knows ERP for OCD.
That's right. And what I would say is, this is what I want a take-home message to be. Depending on your diagnosis, there is specialized treatment interventions for you. So if you live with PTSD, we are going to be talking about cognitive processing therapy, prolonged exposure, and certain evidence-based interventions. For OCD, it's ERP. For BDD, for eating disorders, they all have their own specified interventions. And so to think that the standard OCD approach is going to work across the board, it probably isn't. Just like a standard CBT approach, which might work for, something like depression, isn't going to work for OCD. And so I really would say, like, don't use the same treatment because they're a different diagnosis. And if it's a different diagnosis, you want the specialty treatment. Now, that doesn't mean you won't find a provider who can treat all of them, right? There are certainly providers like Chris and others who specialize in OCD and BDD, but maybe for eating disorder, you do need another provider that specializes in eating disorders, and it can be a team approach. Next question is, how does one with OCD in periods of unemployment due to OCD navigate searching for employment and explain it to potential employers? This is a great question. I'll answer quickly and then Chris hop in. But, I think it's really about, what do you want to share and what do you feel like they need to know? Sometimes people don't need to know the details, and you can say things like, my gap in employment was due to personal reasons and things that I needed to address. But, I am excited to be able to re-engage in the workforce, and it's something I've been looking forward to. It can be short and sweet, or you can choose to disclose at a level that makes sense. What I will say is, think about the level of disclosure, right? You wouldn't disclose everything to somebody you meet on the first date. So should you be disclosing everything to someone at your first interview, right? It may not be necessary, because the reality is that I'm hoping by the time you're searching for employment again, OCD is well managed, and it may not interfere with your work or your ability to function, but up to you really on what you want to disclose as far as explaining the gaps in employment.
I'll just come from a personal experience. I had that same issue as I had when I went out for one of my first jobs. I was really struggling because I had this huge gap. And the way that I addressed it, I don't like to be dishonest. I just don't remember dishonesty if I make up a lie anyways, but I just don't like to come from that angle. And just like Liz said, it was not their business for me to open up about every intrusive thought I've had. So the way that I handled it is I said, I understand that you're concerned about I think it was a 6-year gap at that point. And I just said, look, there was a lot of medical issues and health issues that were impacting my family, and I had to take care of that. But I'm at a place now where I have it handled. It is no longer something that will prevent me from working. And in fact, I'm very encouraged and excited to get back in the workforce starting here at this company. So to me, it was a very honest situation. There was a health issue that was impacting my family. I just knew that there's a lot of people that are out there doing job interviews that will be turned off or not understand mental health, which is super unfair. So just kind of read the room and know what level of comfort you have. I don't recommend lying like, oh, I was in, Tahiti doing a across the school program. I mean, you don't have to be dishonest, but you don't have to open up about everything.
Absolutely. Next question is virtual ERP therapy just as effective as in person?
Yeah, so there was actually a couple of studies that I looked at when the pandemic first hit. Obviously, it wasn't about telehealth around the pandemic. It was just telehealth in general for OCD treatment. I even had an older study that I had used when I was doing my thesis back in grad school. And all the research shows that it is just as effective. What I'll say is that for some people, there's certain things you can do with telehealth that was a struggle to do with in person. So if I have clients that had specified contamination areas in their home that they couldn't bring actually to the office, it's been great to be able to do that. Also, sometimes family members who couldn't come to the office with them, we've been able to do meetings. Not going to lie, I love people and I love being in a room with people. So I really, really enjoy that connection. But I've had so many clients that I've never met in person because of the pandemic who have come in, done treatment, and left in a great, great space. So I would say that absolutely it works. I would suggest telehealth where you can see the clinician. I had a couple clients that requested just traditional phone calls. I don't like that as much, but for some people, that's a better method. But lastly, I would definitely say telehealth is much more effective than no treatment at all.
That's right. And here's what I'll say. I love that we're asking this question because I love that people are not just assuming whatever's offered is going to work, right? I love that we're saying, is this as effective? Does this matter? What we know is we don't really have a reason to believe it's not going to be as effective, but we certainly might find that some folks really want in-person and that might benefit more from it. And we can kind of make case-by-case determinations. But I love this question because I think sometimes those of us with OCD get really excited about just like new stuff and jumping in. And I love somebody who's saying, well, is this useful? Do we know if this works? Does it make sense to jump into this type of treatment? And so keep asking those questions. More importantly, keep asking it for yourself. If you start doing virtual ERP work with someone and you find that it isn't working for you or you're not clicking, that's when it's really important to start thinking about why and what's going on so that you can make sure you get the best care for yourself, because it is still individualized. I know we have 2 more questions and I want to answer them both. So the first one I'll answer quickly. How do I for sure know I have OCD? And they shared some different symptoms. This really needs to be diagnosed by an OCD professional. This is not something Chris and I can answer. What I will tell you is that if you go to an OCD specialist, they should always start with an assessment, not treatment. So the first session should really be a diagnostic assessment where we're asking questions, gathering information to really be able to say, yes, this is OCD and this is the treatment that makes sense. Or, hey, I'm wondering if there could be this going on and what type of treatment, and for us to think together about what treatment makes the most sense for you. So certainly could be OCD, but I would want you to see an OCD provider and really be able to tease that apart. And that goes for everyone here, right? Chris and I could hear some of your symptoms and say, oh yeah, that definitely sounds like OCD, but there also may be a lot of other things going on that maybe even though that is OCD, is there other stuff that needs to be addressed, and treatment should be comprehensive really for you as an individual. The last question I want to get to is, I've recently been diagnosed with OCD after 15 years of living with the condition and a Brazilian native. I feel like I'm having a hard time finding an appropriate line of treatment since the professional environment is highly unspecialized. No experts seem to be reachable, and the only available assistance is lifelong medication. I would like to know what the role of medication in your personal journey is, and through recovery, and what tools we can use ourselves when meaningful CBT is unattainable. So the first thing I want to say actually is please look into Dr. Katia Moritz. She runs a clinic called NBI in Miami. And I believe Katia has a lot of connections and still does a lot of work in Brazil. So there actually might be some resources available that you may or may not know of. So definitely look into that, because we want to make sure if resources are available that you're able to access them. And she could help potentially guide that much more than I can. The second piece that I'll say is I never like to go into details of my journey with or without medication, because I don't want anyone to make decisions based on what I've done. This is really an individual decision, that what works best for you. There is no right, there's no wrong. It's how does your mental health get impacted by different treatment methods, and how is it best reduced or best managed by various treatment approaches, and you making decisions that work the best for you. And there is also online providers who may be able to do treatment in Brazil depending on rules. And so I will say teletherapy, whether we know how effective it is, it certainly has opened many more opportunities now for treatment that didn't previously exist. So don't just assume that treatment doesn't exist for you. The last piece I'll say, and then I'll hand it over to Chris for this final question, is there are amazing self-help books, workbooks, and education and resources online and in different places that you can have access to and that you can utilize to better understand what might exist for you, and for you to better understand OCD and ERP for your specific diagnosis.
Yeah, what I would just had to add is I had a client that moved to Brazil from working with me, and this was a couple years ago, so I don't have the name of the clinician off the top of my head, but they found somebody in, I think is Buenos Aires. No, it's Argentina, right? Is it?
Yeah.
What's the cat? Thank you. Yeah. I'm bad. I had another client go to Argentina, so I was getting them confused. But I had a client that went to Argentina, another client that went to Brazil, and both of them ended up finding specialized treatment. And I had them link in with the IOCDF. I think they even emailed the IOCDF, and the IOCDF sent them some resources in that country. So there is help out there. It might be a little bit more difficult to find, but you can definitely find help.
Absolutely. So I know we're wrapping up, and I just wanted to say thank you. It was such an engaging conversation as always. We love being together with you all, but I will end with my quote I always end with, and this is perfect for the last question we got, but help and hope are always available. Make sure you don't just accept what you first hear. Sometimes we have to advocate extra hard, and we have to navigate resources and systems. Let IOCDF be a partner in helping you do that, and other organizations that exist. Go to iocdf.org for more information, and I cannot wait to see every one of you next week, because it is going to be an awesome live stream that we're going to be joined by Dr. Grayson, who's incredible, and we are really going to talk, the three of us, about do's and don'ts, and bring a lot of questions and ask a lot of things that don't always get answered, but also pose a lot of hard questions that will be really important for us to hear and understand.
Yes, Michelle Hoffman, I want to say real quick, have your child's therapist link up with the counselor at school. That's answering your question. I just always want to say to our OCD community, thank you so much for coming out. This is a labor of love for Liz and I. So we absolutely are so ecstatic that so many people come out each week. If we didn't get to your question, because I know that's something that keeps Liz and I up awake at night, please come back to our live stream next week with Jonathan Grayson. He's an excellent individual to have. You're going to get a treat. He's great. And then, continue to come to our live streams. We will always get to your questions. Definitely go to iocdf.org/peace of mind to submit them ahead of time, or come back live, and we'd love to. But thank you so much for coming. And remember, Liz and I are proof that treatment works. You can get better and live a fulfilled life. So thanks for hanging out with us today on your Wednesday morning, afternoon, or evening.
See you guys next week.
Take care.